This week on Conversations on Healthcare, we welcome Dr. Peter Hotez on his newly deployed low-cost COVID vaccine being made available to poor and developing countries to address the global shortage of vaccines around the world. Now, here's Mark Masselli and Margaret Flinter.
We begin 2022 with a grim statistic. The 7-day average for new COVID cases in the United States has increased 82% compared with the previous 7 days. The dominant variant is Omicron. We're told more variants will be on the way until the world can deploy additional vaccines. Our guest has an intriguing approach that promises hope.
Dr. Peter Hotez of the Texas Children's Hospital Center for Vaccine Development has been called a global health warrior. The center's in its third decade as one of the leading vaccine development centers in the world. And now Dr. Hotez and his colleague have developed Corbevax. It's a low-cost, open-source alternative to the mRNA vaccines, which we're using here in the United States, but which have been slow to roll out in developing and under-vaccinated countries around the globe. But the Indian government has granted emergency approval for its use.
Dr. Hotez, we appreciate you joining us again on Conversations on Healthcare, especially at this critical time, and so many questions to ask about the new vaccine. Where the trials were done, what age range does it cover, how does it work compared to the mRNA vaccines that we are so familiar with in terms of the Moderna and Pfizer, and tell us about its efficacy.
Well, this is a recombinant protein vaccine that's similar to the hepatitis B vaccine that's been in use for 40 years. It's made through microbial fermentation in yeast, and most parents in the US have given it to their kids, or the parents have gotten it to them for themselves when they were kids. So it's got a great safety track record, and the level of virus neutralizing antibody looks pretty exciting in terms of comparable to the mRNA or adenovirus vectored vaccines, but at a fraction of the cost and ability to scale it up. And because this technology is already in place in places like, in terms of the recombinant hepatitis B vaccine, technology is in place already in Indonesia, Bangladesh, Vietnam, Brazil, and India, of course. And so they can easily adopt our approach. So what we do is we develop the prototype vaccine because we develop vaccines for neglected diseases of poverty, been doing that for 20 years, and then transfer the technology with no patents, no strings attached, now to India, Indonesia, Bangladesh, and Botswana. India is the furthest along. They have 150 million doses already ready to go, with plans to scale it to 1 billion doses this year. And it was just got released through Emergency Use Authorization. So everything is really moving pretty well. We could have gone faster had we some support from the G7 countries, but that's life. But in the meantime, we're hoping to make up for some lost time.
Well, Dr. Hotez, thinking back to our last conversation with you, I imagine this has been an incredibly intense year, not a lot of sleep, a lot of work pushing this forward. We want to thank you, as always, for your work, but tell us more. This is major news, obviously, and for India and the other countries that you've described to have access to a new vaccine supply, obviously a huge step forward. But I remember reading back early in the epidemic, responses to vaccines around the world, and India had some of the same issues the United States did around vaccine hesitancy, resistance to vaccines. What are your people on the ground in India telling you about the willingness of people now using India as the country where you're launching this to accept the vaccine and really moving forward to get people vaccinated now that they might have a reliable supply of vaccine?
Well, we're hoping hesitancy will be lower than some of the other technologies because, people of India have already been getting a vaccine of this technology for 4 decades, so they're familiar with it. They know its excellent safety profile. So hopefully that will mitigate it against it somewhat. The other issue is making certain that India will donate doses to the COVAX sharing facility. That's going to be also important. So it's going to be a mixture of vaccines used within India, but also exported to the world. And India has that track record as well. And as I say, India is the first out of the starting gate. Mm-hmm. We're hoping to make similar progress with Indonesia, Bangladesh, and Southern Africa. And if we can get additional support from the US government or others, we can make this arrangement with still other countries as well. And the advantage of the technology, we're not constrained like we are with mRNA and or adenovirus, where there's limits on the amounts you can make. There's sky's the limit for this technology.
You know, we recently had Dr. Hazeltine and Dr. Topol on, who were complaining about the lack of sort of global leadership that's sort of fallen apart. You just mentioned the G7 countries were sort of an obstacle. Talk to us a little more about the difficulty that you encounter, or what road needs to be cleared so that we can start disseminating what sounds like a very easy to produce vaccine. And again, I know it hasn't had a peer review article been published on it yet, but talk a little bit about the global partnerships or lack of.
Well, actually, by the way, we've got about 7 publications on our vaccine. So we put everything in the public domain. So every aspect of its production, its features, its characteristics is out there, and you can just go to the PubMed index and put my name in, and you'll see a fair amount of details about the vaccine. The clinical data has not been published yet, and that's because we provide the vaccine with no strings attached. So it's owned by the company, Biological E, in India, just like it's owned by Biopharm in Indonesia and Septa in Bangladesh. And they work out the publication plan with the Indian regulators. And they say it should be forthcoming very soon. And actually probably will happen faster than the pharma companies did after their vaccines were released for emergency use. So their vaccines had a 3 to 17 week lag before the publication came out after emergency use. I think it'll actually happen faster. So that's moving forward, and I think that's an important point, that there's this concept in global health that we practice, everyone talks about, called decolonization, and that we're not trying to own the technology, we're trying to give it to the countries to empower the countries so they can be out in the lead. So it's looking really exciting, and all that information is forthcoming.
Dr. Hotez, I think that, for those of us just kind of on the front lines trying to respond to all of our communities and our patients, it's a little bit of whiplash this year with COVID. We think we're doing better. We think we're doing worse. Delta arrives, Omicron comes, and I'll tell you, just on the front lines, we're seeing just such dramatic increases in infection. I know that just mirrors the national data, but maybe you could just tell our listeners, is the vaccine that you've developed another tool in the toolbox of vaccines, but one that we believe can be more readily available and distributed because of how you've approached this in terms of the ownership at the country level? Or is there anything fundamentally different in terms of effectiveness, or effectiveness based on the number of doses? Or is it one more good tool or something fundamentally different? Just help our readers get a handle on that, if you would.
Well, the difference is it's produced locally and meant to empower the low and middle income countries to produce their own vaccine. And it could be scaled locally and can be distributed locally. So, and in terms of the nature of the technology, since there's already widespread experience locally to manufacture it, we think this is one that could be made in the billions of doses very quickly. And so if you're talking about vaccinating the Southern Hemisphere, the global South, we think this could move quite quickly. I mean, the truth is, had we a fraction of the funding that Moderna had or Pfizer had from public sources, who knows, the world might have been vaccinated by now, and we would never have heard of something called Omicron. And so that's where the lack of leadership comes, is the G7 countries and the US government have not had that commitment to vaccinating the global South. And as a result, Delta arose out of an unvaccinated population in India earlier this year and last year, and now Omicron out of Southern Africa. And we're going to have other variants of concern arise until we make that commitment to vaccinate the world. And hopefully this will be an important first step.
Yep. Well, that's a pretty important addition to the toolbox. Thank you for clarifying that.
President Biden just spoke to the American people today about the surging Omicron variant and the need to beef up our supplies of therapeutics. He announced that the government was buying 10 million more doses of the Pfizer antiviral. I'm wondering if you could tell us why this therapeutic is so necessary in our toolkit to contain the severe disease and to lower hospitalizations from COVID.
Well, two of our three monoclonal antibodies appear not to work against Omicron, the one from Regeneron and the one from Lilly.
Mm-hmm.
So that's a problem. And all we have in terms of effective therapeutics right now is the monoclonal antibody from GlaxoSmithKline/Vir, and that's only available in limited quantities in hospital formularies, and the remdesivir, which has to be given parenterally. So having Paxlovid, the Pfizer medication, would help a lot. And if we could get that sooner rather than later, that could also make a big difference. And so that is also a priority. But a reason why this Omicron epidemic is so dangerous, we have knocked out some tools that we have in our toolbox for treating it. A lot of healthcare providers are getting sick and can't attend to the patients that are going into hospitals, and the hospitalizations are rising. So even though on average, Omicron may not be as severe as some of the previous lineages, that net aggregate effect of knocking healthcare providers out of the workforce, of not having adequate treatment tools, creates a very dangerous situation for the country.
Well, we are certainly seeing that on the front lines here in the United States every day. But I wonder if I can ask you the strategy of how this really becomes available throughout the world. Are you working with the World Health Organization? Is that part of your strategy as you think about how this vaccine could really get to all corners of the globe and try and bring this pandemic to an end?
It is, and also the developing country vaccine manufacturers. In fact, they call themselves that, the Developing Country Vaccine Manufacturers Network, are now working with the World Health Organization for emergency use listing globally. So BioE has started those discussions with the WHO. We're also in on some of those discussions, because to get this pre-qualified by the World Health Organization makes it much easier for Biological E to export the vaccine to other countries. And so we're moving forward on that as quick as possible.
We're entering 2022. Happy New Year, but it's the third year of the pandemic. We're hit 1 million positive cases the other day. I wonder if you can give our listeners a sense of the arc of this COVID virus, that's pandemic that's going on. What's your sense of what to be hopeful about and what keeps you up at night?
Well, I do think this will subside, and based on the kinetics of the curve of this Omicron wave in the UK and South Africa, hopefully it starts to go down as quickly as it's gone up, and whether or not it plateaus for a while remains to be seen. But eventually this will pass, and then we've got to decide what the world looks like post-Omicron. We know the likely Omicron is probably not going to produce much in the way of durable protection. People will still need to get vaccinated, so that's got to be a priority. It means defeating this very aggressive anti-vaccine activities that are causing people to needlessly lose their lives by being defiant of vaccines. 200,000 Americans since June 1 who refused vaccines lost their lives. So anti-vaccine, anti-science activities are a top killer in the United States. So we've got to figure out how to conquer that. And lastly, we've got to vaccinate the world to prevent the new variants from emerging. If we can do those things, we can get out of it, but it's still a pretty high bar.
Dr. Hotez, I think as the world knows, you are a pediatrician. You're a professor in the Department of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine. And I would imagine that at least once or twice a day, people are asking you what's going to happen with schools. We're post the New Year's holiday, certainly seen huge spikes. There's discussions about whether schools should close, stay open. Certainly seeing increases in numbers of hospitalizations of kids, although probably associated with just the dramatic increase. What are you saying to school superintendents and people there on the ground in Texas who want to know whether we need to close schools again and take the kind of draconian measures that we did earlier in the pandemic in really thought we had moved away from.
Well, in fact, I was just asked about the Mayor of New York's decision to keep schools open. And I said, look, it's a choice between a bad decision and a bad decision. There's no good decision here. If you go back to virtual learning, we know about the harmful effects over the last 2 years on kids, on the mental health of kids, and the Surgeon General came out with his report at the end of the year. On the other hand, trying to do this with at the peak of a variant, which is so highly transmissible, almost to the level of measles, that's going to be really, really tough to manage. So is there a benefit to delaying the opening of schools another couple of weeks and tacking it on in the summer, treating it almost like 2 weeks of snow days? And as I say, I have tremendous empathy and sympathy for administrators making those tough decisions. Yeah. And I could argue it either way. And I think a lot of it has to do with the wishes of the community and the school boards. But either way, it's going to be a very tough decision to make.
Mm-hmm. And another tough decision, certainly for parents of young children, right? Still no vaccine on the horizon, or maybe there is one on the 0 to 5, birth to 5 years old. And this is particularly troublesome for young people, the Omicron variant. Maybe walk through some advice for parents. What should they be watching out for in terms of dealing with the variant? And I don't simply know what parents can do with children in terms of who have no vaccine, but what's your best advice now for parents?
Sure, and then I'm going to have to run, unfortunately. Yeah. But I think the key, first of all, is kids 5 and up are eligible to get vaccinated, and nationally, we're not doing very well vaccinating the 5 to 11-year-olds. Only about 15-20% of kids are eligible, are getting vaccinated. So I think there's room there. Even among the teenagers, we're not seeing good vaccination rates. In the Northeast, a little better, about 75%, but only about half that in the South. So I think maximizing out the use of vaccines for 5 and up is going to be of paramount importance. And then for the little kids, trying to keep them safe, under 5 years of age. I don't think we'll have vaccines in the U.S. available anytime in the immediate future. We're trying to do that now in India and globally with our vaccine. So this is the reason for being conservative and trying to make sure you kids wear masks in school so they're not bringing the virus home to the family.
Dr. Hotez, congratulations on the development of this new vaccine. We'll be following its path from your lab to India and beyond. You can follow Dr. Hotez's work by going to bcm.edu/National School of Tropical Medicine, or follow him on Twitter at Peter Hotez. That's Hotez. Dr. Hotez, thank you so much for joining us once again on Conversations on Healthcare. Good luck.
Thanks so much, and thanks for all your great work, and all the best to you.
All right, thanks so much. Talk to you soon. Ciao.
Bye-bye.